Welcome to respiratory physiology. The first thing that we need to remind ourselves when we think about respiratory physiology is the primary function of the lungs. In the lungs, function follows structure, and the primary function is gas exchange. There's two parts to gas exchange. There's oxygenation, which is bringing your O2 in, and ventilation, which is taking your CO2 out. Both of these are determined by our metabolic needs at the level of the tissues, and are regulated by the relationship, or are manifested by the relationship between the structure of the bronchioles and the mechanics of breathing. So a quick reminder, the muscles of inspiration include the diaphragm, the intercostals, as well as the accessory muscles. Two things about breathing mechanics that are extremely important is that unlabored breathing, expiration is passive, and your inspiration is your active part. The structure of the bronchioles starts with the conducting zone down from the trachea through the terminal bronchioles, and the transitional and respiratory zones include the respiratory bronchioles down to the alveolar sacs. Our conducting airways are essentially anatomic dead space. You can get additional dead space in the respiratory exchanging airways. That's called physiologic dead space when you have ventilation perfusion mismatch. So during inspiration, volume of the thoracic cavity increases. Air is drawn into the lung. This is an active process, like I've said, and drives change in pressures among by the diaphragm and the intercostals. Beyond the bronchioles, when we get down into the terminal respiratory gas exchange area, it's important to remember that the cross-sectional area of the airways is enormous, 50 to 100 meters squared, and forward velocity of the gas becomes very small with this large volume. Diffusion at this point will take over since the blood-gas interface is extremely thin, only 0.2 to 0.3 microns. The other important part of breathing mechanics is that the lung is elastic and passively returns to its pre-inspiratory volume without additional effort. In fact, the lung is so elastic that a normal breath of 500 mLs only requires a 3 centimeter difference in pressures. When you talk about the volumes of the lung, there's a number of definitions that have been provided to you in your PowerPoint notes. And these are unique and separate from our capacities. It's worth reviewing these definitions when you're thinking about respiratory physiology. Our static lung volumes are essentially our normal breathing, which is our tidal volume. And we need to remember that our tidal volume includes mixture of gas from anatomic dead space as well as alveolar gas. So not all of the volume that you breathe in is going to be contributing to your respiratory exchange. Our exhaled volume, on the other hand, is our vital capacity. Gas will remain in the lung after maximal expiration is called our residual volume. You can see this on this diagram of spirometry. One of the most important values in our capacities that needs to be considered for physiology is the functional residual capacity, or the FRC. The functional residual capacity is the volume of gas in the lung after normal expiration. And the special purpose of this is that it must be above closing capacity of the alveoli to prevent atelectasis. Equilibrium volume when the elastic recoil of the lung is balanced is the normal tendency of the chest wall to spring out at the end of exhalation. And the numbers in regards to some averages for how much dead space is involved is our anatomic dead space has approximately 150 mLs, and it's the air in our conducting airways. The alveolar region holds between 2.5 and 3 liters. And our physiologic dead space, as a reminder, is the volume of air that does not participate in gas exchange. So when we think about the process of breathing, we remember that you increase the volume in the lung by using your respiratory muscles, which decreases the interthoracic pressure, which allows air to flow downward into the lungs. Expiration then occurs by elastic recoil, is passive, and the elastic properties of the lungs. Part of this relationship is what we call the compliance. This is the relationship between volume in the lungs and the pressure in the lungs. This essentially describes the distensibility of the lungs by assessing the change in volume for a given pressure. And there's two things to consider for this. The mathematical equation for compliance is the inverse ratio of volume in relationship to pressure. The change in the pressure with increasing volume is the compliance or slope of the line and is nonlinear, with increasing volumes of lungs becoming slightly stiffer. This curve can be affected, of course, by pathology. The slope you see here is different between inspiration and expiration, which makes sense because inspiration is active and expiration is passive and rely on slightly different forces. This difference in curve is called a property of hysteresis. So we have increase in the volume of the chest cage, lowering our interpleural pressure. Another important factor to consider then is surface tension. So surface tension can be defined by Laplace's law, which is pressure equals 2 times the tension divided by the radius. So the smaller the radius, the higher the surface tension, or the higher the pressure